In this video I am going to talk about crystalline arthropathy, which are a group of joint disorder caused by deposits of crystals in joints and soft tissue around them. The most common types are gout. But let's talk about physiology first. Purine together with pyrimidines are key components of nucleic acid like DNA and RNA. Purines are first broken down into adenosine monophosphate or AMP and guanosine monophosphate or GMP. AMP is converted into inosine monophosphate IMP. GMP is converted to guanosine, and by two different mechanisms, both IMP and adenosine are converted into inosine. Guanosine is converted to guanine. Inosine is then converted to hypoxanthine and guanine to xanthine by xanthine oxidase enzyme. Hypoxanthine is converted to xanthine, which is finally metabolized to uric acid, which is the final product of purine metabolism. Now, under normal physiologic conditions, uric acid circulates in plasma and synovial fluid as ureatine ions. Body can avoid excess uric acid by recycling purines via purine sulfate pathway. This is when organs convert hypoxanthine back to inosine monophosphate by hypoxanthine guanine phosphorhypoxyl transferase HGPRT, which then gets converted to AMP to make new purines. Conversely, we can take guanine and convert it to guanosine monophosphate by HGPRT enzyme to make new purines. However, human tissues have limited ability to metabolize urate, thus it's quickly eliminated by the body to maintain urate homeostasis. Uric acid is eliminated by the kidney. About 2/3 enters the abdominal aorta, renal artery, then filtered inside the kidney to be eliminated inside urine. About 2/3 of uric acid is excreted by the kidneys, and the remaining part is excreted by intestinal system. Here is the mucosa of intestine and the blood vessels beneath the basement membrane. Food is transformed into uric acid as we discussed before, and then uric acid inside the lumen, uric acid inside the blood. Uric acid inside the blood transported into intestinal lumen, then excreted in stool. About 1/3 of urate is excreted in stool after intestinal secretion and urinolysis. Now, gout is a monoarticular inflammatory disease caused by deposition of monosodium urate crystals. That's a blood vessel and its endothelial lining. Uric acid found circulating freely inside blood vessels. When levels become very high and plasma becomes saturated with uric acid molecules, it's hyperuricemia. These molecules start binding sodium to form monosodium urate crystals that start deposition, especially in areas with slow blood flow, like the joints and kidney tubules. So the main causes of gout is excess uric acid or hyperuricemia, and it can be caused by overproduction or under excretion. That's renal structural unit, the nephron. It's a proximal convoluted tubule, lobe of Henle, afferent arteriole, glomerulus, and efferent arteriole. Uric acid filtered in renal glomerulus to proximal convoluted tubule to be excreted in urine. If there is renal failure, no glomerular filtration rate, no GFR, and uric acid bypass glomerulus and become trapped inside blood vessels, especially efferent arteriole. Filtered uric acid can be returned from proximal convoluted tubule into blood vessels by reabsorption. If reabsorption is enhanced, it leads to hyperuricemia, and it can be idiopathic or due to certain drugs such as thiazide and loop diuretics, angiotensin converting enzyme inhibitors, and angiotensin receptor blockers. Also can be enhanced by lactic acidosis, ketones, and alcohol consumption. There is another process called renal secretion. Uric acid is secreted from blood vessels into proximal convoluted tubule. Low-dose aspirin can inhibit renal secretion, keeping uric acid inside blood vessels and causing hyperuricemia. Risk factors for gout are elderly male, diabetic, hypertensive, consuming a lot of alcohol. Overproduction can be due to increased intake of purine sources as red meat and shellfish. Others might have a genetic predisposition to overproduction of uric acid, or it can be developed as a result of myeloproliferative disorders. That's a long bone with bone marrow inside it. Proliferation of bone marrow cells, red blood cells RBCs, platelets, or white blood cells YBCs, leading to polycythemia, essential thrombocytopenia, and leukemia, respectively. Rapid proliferation means a lot of cells with rapid cell turnover, and purine release, so increased uric acid formation. Other people undergo chemotherapy or radiotherapy where a lot of tumor cells die, causing what is known as tumor lysis syndrome. Dead cells release their content into bloodstream, resulting in increased levels of potassium, causing hyperkalemia, phosphate, causing hyperphosphatemia, and uric acid, causing hyperuricemia. Finally, there are some rare causes of uric acid overproduction that are high yield. For example, hypoxanthine guanine phosphoribosyl transferase deficiency in Lesch-Nyhan syndrome, which is an X-linked genetic disorder causing hyperuricemia secondary to decreased purine recycling through purine salvage pathway. Then we have phosphoribosyl pyrophosphate synthase excess, which leading to excess formation of uric acid from phosphoribosyl pyrophosphate, which is a precursor of uric acid synthesis. A final one is von Gerkes disease, a glycogen storage disease, where his body cannot break down glycogen by transforming glucose 6-phosphate to glucose due to deficiency of glucose 6-phosphatase enzyme, leading to formation of pyruvate. Excess pyruvate leading to prevention of transforming lactic acid into pyruvate, and formation of new lactic acid leading to lactic acidosis, which stimulates reabsorption of uric acid through proximal convoluted tubules. When monosodium urate crystals deposited somewhere in the body, macrophages travel to that area to engulf and phagocytose to destroy that uric acid crystals. Now macrophages become stimulated and become active to secrete specific types of protein called cytokines, tumor necrosis factor alpha, interleukin 6, and interleukin 8. They cause chemotaxis and bring other immune cells to the area of inflammation. Polymorph nuclear lymphocytes, macrophage, and monocytes. These cells infiltrate joints and renal tubules to cause inflammation and damage by producing a lot of cytokines to cause arthritis if they affecting the joint. That arthritis resolves spontaneously in 5 to 14 days because of a specific type of T lymphocytes called T regulatory lymphocytes that produce anti-inflammatory cytokines, for example interleukin 10, to stop that inflammatory state and cause remission of that gouty attack. Gout has relapsing remittent course with free periods between attacks. Classically, in acute gout attack, uric acid crystals deposition cause an inflammatory process in joints. The affected joint is red hot, tender, and swollen due to that inflammatory state. First, metatarsophalangeal joint is the classic and most common site for acute gouty attacks. It's affected in symmetrical fashion and called podagra. Pain is so severe over the affected joint, especially at early morning, or may awaken the patient at night, feeling like their big toe is on fire. Also, stiffness is found. Pain decreases over time because of the effect of T regulatory lymphocytes that suppress inflammation by producing anti-inflammatory cytokines over 5 to 14 days. If cytokines reach systemic circulation, it may cause systemic symptoms like fever, headache, malaise, and other during the attack. Also, interleukin 6 stimulate liver to produce acute phase proteins or acute phase reactant. C-reactive protein is high. Also, there is elevated ESR and leukocytosis. Repeated attacks cause chronic gout. The clinical picture is dominated by the presence of tophi around the affected joint. Classically affects the dorsum of the hand. These tophi can even develop in unexpected places, like the extensor surfaces, as elbow, knees, Achilles tendon, and the external ear or the auricle. Patients can also develop uric acid kidney stone. They might present with symptoms like lumbar pain that radiates to the lower abdomen and the groin. Pain on urination and hematuria also found. Diagnosis is based on blood testing to detect the level of uric acid. Check renal function tests, serum urea and serum creatinine. ESR and CRP also high. White blood cells also elevated in the form of leukocytosis. Joint erosion may be seen on X-ray in the case of chronic gout. Soft tissue swelling also found over the affected joint. Joint aspiration is the definitive diagnosis. Treatment options: acute or chronic. Acute cases usually treated by colchicine, which is the drug of choice in case of acute gout. Non-steroidal anti-inflammatory drugs is an alternative. Both colchicine and non-steroidal anti-inflammatory drugs are avoided in renal patient. Renal patient is given steroids or anakinra. Chronic cases given allopurinol, which is the drug of choice. Febuxostat also be given. Uricosuric drugs also given. Febuxostat and allopurinol prevent xanthine oxidase, which is the final enzyme